now we will hear from Kathy Kelly, the Executive Director of the Family Caregiver Alliance.
And I had some PowerPoints. Oh, there they are. Hey, good morning. Thank you for inviting me today to talk about the needs and wants of family caregivers for this most important study on the family caregiving for older adults. My talk is brief, and I want to preface my comments by stating that the information provided, thank you. Okay. Information is provided is born from service experience with family caregivers over a period of many years at Family Caregiver Alliance, both within California and from handling calls across the country from families seeking services and through our work of analyzing caregiver data from service systems. I assume that the surveys and the heavy statistical information regarding the surveys will all be readily shared, but I'd rather talk about the needs of family caregivers from the collective wisdom of the families who have contacted us. As Carol said, we were talking last night, the refrain I often hear from individuals and actually from policymakers too is, isn't caregiving just something that families have always done? And I didn't take this picture off the internet. It actually is part of my family. And the answer to that is yes and no. The answer is yes, of course. Care for relatives is a basic assumption of reciprocity within families. It is the most basic unit of care after self-care. However, what families are facing now in terms of care for older adults is unprecedented in terms of duration, complexity, and cost to caregiving individuals. If we just look back briefly to 50 years ago, I dare say within the memory of most everybody in this room, 65, when Medicare was established, the Beatles had already made a beachhead in the United States. A good year as a takeoff benchmark point of how things have really radically changed. We'll see the changes that in our society that really make the notion that families can do it all by themselves rather quaint. There's an increased life expectancy that we have now, but at the time, 1965, the average life expectancy for a man was 66.7, and for women, it's 72 years. Today, it's 84 and 86. We just simply did not have the same risk factors in relative to age for some of these chronic conditions as we do now. Many of the conditions that we talk about, the kinds of drug treatments and other kinds of interventions to manage chronic care conditions didn't exist. It just wasn't that long-term caregiving was not going on in 1965. Of course it was, particularly with children with disabilities and individuals that were coming out of rehab, and some of the earliest writings are really in the nursing field around rehab related to family caregivers, but just wasn't as prevalent as it is now. There's increased complexity in the healthcare and costs. We see, already made reference to that, and I'm sure you'll delve into this in more detail. With the addition of treatments for chronic care comes the increasing complexity in the management of these kinds of conditions. In 1965, over half the physicians were primary care. Now it's less than a third. The rise in specialists, while it's all very well and fine and certainly does add to the fact that we can manage these kinds of conditions, just complicates coordination for everyone. If you were to be blindfolded, spun around, and dropped into a setting where you did not know the language or customs, and then were expected to make choices about very complicated decisions for yourself or for others, this might be the best description of how families feel when they enter the healthcare system. Basic healthcare costs have risen, of course, but the other series of costs that we don't really factor in is the cost and anticipated cost of long-term care services. You know, I don't know if you have noticed the ads going on now, but they're saying, oh, you need to save $250,000, $300,000 for long-term care costs. This just wasn't a factor. The radical changes in women's roles, I can't underscore this enough because this has the most significant impact on family caregiving. In 1965, and Carol did verify this, over half the women were married by the age of 20 and they completed their families by 30. In 65, less than 10% of households were women. Now it's headed by women. Now it's closer to 40%. Women are now half the workforce, and the need for two incomes is paramount for families to really survive in the US. Women now complete college degrees at higher rates than men. This is a significant impact in terms of looking about towards the future of who's going to provide this care. There's a decrease in size and number of families. Nuclear families were the norm in 65. Now almost 30% of individuals live in single households. Individuals who are never married, divorced families, people who are married with no children, this is really the new norm in terms of our family constellations. But despite all these changes, we are, as a society, expecting families to be more involved in care over the long term than they ever were before. In terms of needs and family caregiving, in working with families over the long term and really getting to know their situation, if you've seen one caregiving family, you've just seen one caregiving family. Of course, in assessing the needs of caregivers, you'll quickly realize that that there are, characteristics and needs and stuff that flow over, all families. But the differences can stem from the size and constellation of the extended family, how many family members and friends are involved, or who could be involved in care. And one of our most common assumptions is that a bigger family means that more caregivers and support is available, and we often see that that's not exactly true, and somewhat misguided. But conversely, we almost always hear from single children who say, wow, tag, I'm it. I'm really alone. And for a single child, they have an extra burden because they don't have siblings to share all the decisions with for their family member. The cohesion and quality of family relationships is really important. Not all families are happy. Not all families are functional. I would say that if you checked your Facebook during the holidays, it might belie this notion. But the fact is that families, even in the best of families, those that are functional and reasonably happy and have worked out all of their family dynamics and history, long-term caregiving causes stress for individuals and across the families, even in the best of families. It seems like everyone can pull it together for short-term crises of a few weeks, a few months, maybe even a year. But years of care interrupted by periodic health crisis episodes is really another story. Family dynamics are especially key when big decisions need to be made about treatments, expenditures, and end-of-life care. And everyone in the healthcare system is replete with stories about the bedside conversations and arguments about what to do about big decisions. The culture of families is oftentimes relegated to the culture of ethnicity, but that's only one part, and it's a part that's a very complicated issue as well. In terms of the acculturation, how culturally identified with that ethnicity the individual family members are. But it also includes religious beliefs, political leanings, sexual orientation of some of the members within the family, and the history of the family too. How did they handle difficulties in the past? Socioeconomic status, we don't really talk about it this much, but actually money comes into play quite a bit in our conversations with families. Have all family members been successful? Have they had access to education, job opportunities? Or is there inequality within the family? Who is successful and who is not, especially in terms of financial success, often determines who the primary caregiver is within the family. So what are the needs? Of course, information is the most cross-cutting. Everybody needs information. The topics are extensive. We probably have 100 different topics in terms of consumer information pieces in our offices. And we're in our office, and we always add more content as we move along. New topics come up. But here's the key. Information needs are dynamic and change over time. And mostly caregivers get too much information. It's ubiquitous. If you Googled family caregiving in any kind of permutation, you'll get millions of responses back from the internet. So we have an information overload, but there's not enough curating of information to the needs of the family at that particular time. Emotional support. Frankly, these are not in any sort of rank order, but I moved this one up the list. I had sort of unconsciously put it towards the bottom because it sounds soft and not transactional. It's not something that you can see a skill, teach a skill, check it off your list. But truthfully, after information, emotional support is pretty much at the top of the needs list for families. It just permeates all of the interactions of care. In the impact of a caregiver, observing the health and functional changes in your family member, you're also mourning the past relationship you have, you're reframing the current relationship with a care receiver, doing tasks that you never expected to do, like intimate care for parents, has a profound impact emotionally on individuals. The changes also impact the caregiver's expectations for the future. We're going to travel, we're going to do this and that, and so on. So it's a huge impact. In terms of decision support, the current challenges or difficult situations that are currently and then also in the future, families need help with that. And then linkage to formal services and community, and really to have the ability to ask permission to involve other family members and give them tasks is a critical concern.
Kathy, we're going to have to wrap up.
Okay. Okay, so I'm going to just touch on financial information, benefits counseling, because I think we have not paid enough attention. We talk about this in terms of reference to the care recipient, but the caregiver themselves also needs financial counseling about the impact, long-term impact of dropping out of the workforce and how can they reenter and how can they reenter and actually how can they survive financially in their current state. In terms of wants, families need to be recognized for the value and complexity of the work that they do. They need to not be ignored within the health and social service system. We need to have honest healthcare conversations with providers. We also need to pay attention to the financial setbacks that can be a result of providing care to a family member. And healthcare interactions and system development needs to be truly person and family centered and to prize convenience in service delivery to the family and the patient. And if one thing I've heard over the years is I wish I just had one person to call or a couple of people to call as trusted advisors instead of a round robin of conversations where you're telling your story over and over again. The last slide is just a summary, and I would just like to say the world has changed, and with it, the capacity and ability and expectations of families to be the sole providers of long-term care in the home also needs to be changed. If we as a society hold the expectation of increasingly complex care as to be provided to the long term by unpaid caregivers, then society must also provide the support necessary for family caregivers to be successful, not only in their current role as a care provider, but also secure their return to the workforce or to a financially sound retirement.
Thank you very much, and we'll have Kathy's slides for the record.